Good morning, everyone, and welcome to Grand Rounds. Our topic for this morning is challenges in the management of both female and male infertility. And if I may dare say that the infertility story has been one of the few successful stories in medicine. I always think of medicine in general. There are very few treatments that are really available for any disease that you have. So if you have liver disease, unless you really have a liver transplant, most liver disease are untreatable. If you have a lung disease, most of them are untreatable. You can just sustain people, but you really can never cure anything, can never reverse anything in the broad spectrum of medicine. Fertility was the same for literally 20 centuries. And for 20 centuries, the whole treatment was based on ideas and concepts and so on, but there was no science behind it, and there was no progress whatsoever made. So basically, if a couple was infertile, the only option that was available for 20 centuries was sperm donation. That was the only option that has been practiced for centuries. But until recently, all this has changed. And really it changed because of two men that worked very, very hard on making this happen. The gentleman on the left is Dr. Patrick Steptoe, and the right is Robert Edwards. Patrick Steptoe was a gynecologist in a small hospital in northern England, in a town called Oldham, that is almost hardly known in the medical field in their establishment, even if you grew up in the UK. He was in the war, in the Second World War, and came back and could not really get a good job in London, so he settled for a small job up in Oldham. And then a few years later, he decided to go to Paris, because there was, at the time, one gynecologist in the world that did laparoscopy. His name was Raoul Palmer. So Palmer was a French gynecologist who was world-renowned, but he was for one thing, which basically putting a telescope inside the belly, and that was the only achievement that Steptoe was aspiring to acquire. So he went and did a sabbatical with him. He left really his department and went to Paris to do a 6-month sabbatical with him. After 6 months, he learned laparoscopy and came back and introduced it to the UK. The medical establishment at the time considered it a heretical treatment, that you're putting a telescope before looking. So everybody in the world, when they operated, they opened up and then they put instruments. Well, this guy comes and puts instruments and then see after he puts the instruments what happened. So they were very close to the point of really almost stopping him from practicing medicine. So they invited him one evening to give a talk at the Royal Society of Medicine, which is basically a small club that you come in the evening, have a beer, and then discuss a new topic in medicine. Say, well, I found this treatment for that disease, or I found that treatment for that disease. So he came and gave a topic about this laparoscopy. This was literally at the end of the 1950s and the beginning of the 60s. So Robert Edwards heard about it, that he is giving this talk, so he went and attended. Robert Edwards was a scientist. He originally did his major work in Edinburgh, in Scotland, and then moved to the University of Cambridge as a professor of physiology at the University of Cambridge. So he was working on gametes and eggs from literally the 50s. So he almost, at the time, has successfully did in vitro fertilization in many animal species, almost in every animal species that one is aware of. So he went to attend Steptoe's talk about laparoscopy and how it's going. And then at the end he asked him, he said, I have one question for you. Can you see the ovary? He said, I think I could. He said, if you can see the ovary, if I give you like catheters and needles, can you get me the oocytes? And he said, yes, I think I could try that. And they started their collaboration from the 1960s together. Oldham is like several hours from Cambridge, and so it was a very difficult collaboration for Professor Edwards to go up north and do it. And Steptoe had nothing to do with Cambridge or London, so he tried actually several of the gynecologists in London. All the famous guys literally kicked him out of the operating room, said we have enough work to do. One or two guys in northwest of London agreed, so he couldn't afford the gas to drive, so he literally took his bike every day, 3.5 hours to drive and get the eggs, and then come back the next day, 3.5 hours, for a decade of time to get the eggs in London. Eventually, and eventually is a long term because it was a decade, it worked. It worked in the sense that they fertilized the eggs. They fertilized the eggs in the physiology laboratory in Downing Street in Cambridge, and it eventually, succeeded in making embryos. This is still far, far away from having any pregnancies at that time, but it was still amazing for him that he could achieve embryos in vitro at the time, because at the time you have to consider many things that most of the very basic facts in physiology were unknown. Like, the time from the LH surge till the egg is released was unknown. Is this 30 hours or 40 hours or 50 hours? So if you go 30 hours, the egg is immature. If you go 50 hours, it's ovulated. All this has been deciphered. So really he was a biochemist, endocrinologist, geneticist, everything himself. He did the whole thing. There was nobody else that really collaborated with him at the time. Until eventually he achieved the first pregnancy in 76, which was an ectopic pregnancy, and ended like that. And they reported it as an ectopic pregnancy. And then in 1978, Louise Brown was born. So July of 78, 35 years ago or more, was a major landmark, as this was the first successful pregnancy from in vitro fertilization with the birth of Louise Brown. Mrs. Brown basically had tubal disease. The concepts of the two guys were totally different. So Steptoe was a gynecologist. All he was concerned about is tubal disease and pelvic disease and adhesions. He operated on the tube. He failed. So in vitro fertilization was a way to bypass the tubes. This is the extent of his knowledge about the field. Edwards was a scientist. His aim was to cure human disease. And we're not talking about infertility. His first aim was to work on the genetics of the embryo so that you cure the disease genetically before people was born. And then his next door neighbor, her kid died from cancer, so he was very affected by that. He said, well, if we can, make some changes in the genes, then we can possibly cure that before it reaches to that point. So this was his whole objective. He wasn't really into infertility. And the other guy had no idea even what they're talking about. All he knew is that he operated on fallopian tube disease when they had PID. If the tubes were not opened, he failed. If they were opened, he was a hero. So this was the extent of that cooperation. Mrs. Brown had severe preeclampsia, so they had to deliver her. The news in the UK heard about the delivery, so they all came and waited for the delivery, for the C-section to be done. So typically he went out and told them nothing is happening and the pregnancy is still going, send them home, and then came back at 4 in the morning, 4 hours before they start, and did the C-section. And I have still the video where he is actually looking at Louise Brown and counting the fingers in disbelief that this actually happened, that you have a baby and the baby looks normal. This is where it all really happened. And again, like many things in science and in medicine, although Professor Edwards was a well-known professor of physiology at the university, all the university hierarchy did not believe that his scientific work will result in anything. So the University of Cambridge, which is probably one of the major leading institutions in science in the history of mankind, did not support the idea whatsoever. It was actually an American lady that was retired in England. She heard the news, that this guy in Cambridge is working on embryos and curing infertility, and she had no children. Her husband died. So she called him to make a donation. He actually thought it was like candid camera or something, because everybody was attacking him. It wasn't, his career is the most glamorous and the most successful, but really his life was the most difficult that you can ever imagine, because everybody was opposed, including all the chairs in Cambridge, the deans, and so on. So every time he applied for a major grant from the University from London, from the MRC, the Medical Research Council in London, before he arrived, the guys in Cambridge called them and blocked it. So he arrived, and it failed before the even train arrived in London. So it was a series of fights, and then they took him to 50 courts that this was, unacceptable and unethical and so forth. So this lady calls in and wants to donate some money. So he thought this was, of course, a joke. And then he talks for her for a minute or two, and then found that she was really serious. So this was a little village called Bourne outside of Cambridge. Cambridge is actually a small town, not a big town, but outside it there is a bunch of small nice villages in the countryside, and that village, all it had was a little pub and a little house called, actually it's a big mansion and few houses beside it. That mansion was a 13th century mansion that has never been used for years. So she told him, what if she buys that for them? And she bought all the houses on the side of the street, so all the patients were inpatients. All couples came in and spent a week, two, whatever the treatment took, and it was totally free on this lady alone. So her contribution has been significant. On this side, this was really like the restaurant or the doctor's lounge, if you want to say. So everybody comes and have free meals, a day, and so forth. This was the main operating room, and so on. The lab was in the place where the IVF lab, the first world IVF lab, was in the place where the horse stables were kept. That is the only thing they could afford for a long decade. The success, of course, became well known worldwide, and people literally, more people came to the UK for treatment of infertility than they came for anything else. If you think of it, I mean, historically, people came to Europe for treatment mainly for heart disease because of London's fame with heart surgeons, as in Houston and Cleveland and so on. Now, and also for liver disease. I mean, there was some famous liver people that treated. So this was the first time that people came. We celebrated with him. The landmarks of success. This was the last one. This was the 30 years of success, which was in 2008. It was actually in Alexandria in Egypt, and here is Professor Edwards. We're giving him the award from the governor of Alexandria at the time. With actually many of the people in the back were his own students. So actually behind in the back is S.L. Tan, chairman of the current of McGill University in Canada. He was the fellow after me. Antonio Makarigianakis is the chairman in Greece, and Ioannis Messinis, and so forth. All those guys have worked with him for decades. Literally that day, everybody came in from every country in the world. On this side, Professor Aburgar, my co-author and friend, he's also the first guy to do IVF in the Middle East, was currently doing one of the world's largest programs, and then took a turn into politics with all our events. So now he's the head of one of the major political parties. This picture is in the Library of Alexandria. The Library of Alexandria is probably one of the most historical places as far as science has ever happened. The School of Alexandria was started 3 centuries BC. I mean, after Alexander the Great died, the kingdom kind of divided, and the Ptolemies ruled Egypt. And there were 16 of them. The second and the third guy were very keen on science. So the third guy was the guy that started the School of Alexandria as a school of philosophy. So he brought all the Greek philosophers and so on, and the school remained the most advanced school of philosophy literally in the world known at the time, because the whole world was revolving around the Mediterranean Sea. And then when Christianity came to Egypt in the 1st century, the same school that was basically philosophic school became the first Christian school and so on, and first Bible school. St. Mark actually was the first to preach Christianity in Egypt, and history has it that he converted the school. I think it happened after him. And then after him, there was a series of legendary teachers in the School of Alexandria for the first 4 to 5 centuries. So there was famous guys like a guy called Pantaeus and Clement and Origen and so forth. Not deviating, but Origen basically written in the 3rd century, the end of the 2nd century to the middle of the 3rd century, 6,000 books, to the point that even his enemies said that there is no man that he could in his lifetime read what Origen has written. The Library of Alexandria was great. Sadly, the library was burnt, possibly with the Arab conquest of Egypt a few centuries later, which was the world's largest source of information, had all the stuff from 3 to 1000 BCs up till that period of time. So this was in the Library of Alexandria. The library was renovated by our former president. His wife was very keen on Mrs. Suzanne Mubarak was very keen on making the library a major international event. So they got the Danish government built a new library. So this was in the library. He arrived there to give his opening talk, and literally everybody in the world in IVF came to attend his talk. We arrived the night before. He was coming in the morning. He was flying from Heathrow Airport in London. he kept writing a paper, and this is the age of 85, until 4 in the morning. So he was so tired. He arrived at 8 o'clock to give his opening speech in the Alexandria. And this was the legendary man, the man that all my life I heard him give the most eloquent speeches ever, could not say 3 coherent sentences. I mean, he started and he was so tired. I was 85, up all night working on a paper, take a plane and then a train and then a taxi and all that. I arrived to the Library of Alexandria and couldn't say. So we asked him just to come down and sit down, and we postponed the opening, and he had a nap and then came back and gave one of his best speeches ever. Sadly, he's been ill, and this was 30 years of IVF in 2008. In 2010, he got the Nobel Prize for IVF, and then he passed away last year. Sadly, unfortunately, he was very sick when he got the Nobel Prize. And many of his students got the Nobel Prize before him based on much smaller contributions, but literally there was so much opposition to IVF that every time he was nominated from 1978 up to 2010, it was rejected. And then when they felt that the time is getting too late, eventually he got the Nobel Prize. Same with Patrick Steptoe. He had cancer, and he was knighted by the Queen of England, and he was supposed to arrive to Buckingham Palace to receive the knighthood, and actually died the week before from metastatic cancer. So many of those things do not, the people that did them did major achievements, but their own lives was as tough and as difficult as they come. His major, really, and this is his major contribution is that he overcomes so many obstacles. If you think of it, of infertility, you either have ovaries that don't make eggs, tubes that are blocked, men that cannot produce sperm, or men that can produce sperm that do not fertilize. So how can you overcome this? This was really their decades worth of work. So the first part was really to produce eggs. And unfortunately, at the time, there was no hormones. You can measure a hormone. You can take a blood sample and send it to a hormone. And there was no ultrasound. There was nothing called ultrasound. So you can check follicles and so on. So all he did, he collected urine 24 hours and then sent it to a lab somewhere in the UK, which after 2 days of driving with the samples, somebody calls with the results when it is about too late. So he kept all the patients inpatients and so on. So moving the ovulation was a major challenge. Producing multiple eggs or producing an egg was a major challenge in there. And actually, the greatest credit for that comes to 2 landmark events. So I'll try and focus this today on the landmark events. To one of the American gynecologists, his name is Howard Jones. Howard Jones was professor of gynecology at Johns Hopkins. And Howard Jones is considered by U.S. gynecologists as the legend. There are very few people that have contributed as much. He is today 103 years old, and he goes to the office every day at the age of 103 today. They drive into the office every morning. I was honored in 2008. We wrote a big textbook on in vitro fertilization. I was 47. He was 94 then. And I asked him to write the foreword to the book, and he read all 75 chapters and summarized them and wrote a coherent, unbelievably elegant statement. He was a fantastic man. Howard Jones started as a general surgeon before there was gynecology, and then when gynecology and cancer became something, he became a gynecological oncologist. And then his wife, as they were driving back and forth to Hopkins, stimulated him to think about hormones. So they started reproductive endocrinology. There was nothing called reproductive endocrinology at the time. This was the 40s and the 50s. So his wife, Georgiana Seeger Jones, was the first one to discuss progesterone in the luteal phase in 1948 and so forth. Eventually, Howard Jones was the only guy that convinced Bob Edwards to use gonadotropins. Before that, in the UK, they used nothing. So Louise Brown, all these were natural cycles where there were no stimulation. There was no fertility drugs. And then Bob Edwards was using clomiphene citrate. And Howard Jones used always to joke to him, tell him, you still use that toxic stuff. Because he believed that clomiphene is harmful and it is gonadotropin. So really, one of the biggest contribution to Howard Jones in the early 80s, because the U.S. was literally 4 years behind. Edwards achieved the first pregnancy in 78. It was 4 years until the U.S. could achieve the first, which is in in time of nations is a long, long time. I mean, to have 4 years behind one man, you know. But Howard Jones is the man credited with the stimulation of the eggs. We'll come to the fertilization part. All Bob Edwards could do was mix them, like take an egg, put it, and then put a bunch of sperms beside it and wait for and hope for the best. I'll talk a little bit about that. And in his time, he developed a small catheter to put the embryos back. And believe it or not, until today, we use the same catheter. I use the same catheter that he developed, and the whole world, the majority of the world uses the same catheter that he developed. So there is so much achievements about that, and so much achievements here that we'll discuss today. For the gonadotropins, basically Howard Jones was the man that laid it. He decided that the way to go is to produce multiple follicles by using gonadotropins. They had a meeting in Cambridge. They got all the reproductive endocrinologists that were involved, and they had a vote, and the vote came in his favor because there was no evidence. I mean, most people that had pregnancies by the time first were the British, then the Australians. I mean, all used natural cycles. Natural cycles mean no drugs, no fertility drugs. They're just waiting for the egg to mature on its own at the time. Really, it is not flask or tubes. It was Petri dishes that they put the embryos in at the time with Steptoe and Edwards. But really, even those Petri dishes or flasks got terribly negative reputation. So all the people in that village in Bourne, and you would like to think of it as the most advanced. So Cambridge is a very powerful, scientific city. But all those villages, they really thought that they are growing babies in tubes and test tubes and so on. So they thought that this is like a haunted place or something. So it was the public opposition was unbelievably tremendous against in vitro fertilization in the UK in the 70s, and he was taken to court on many occasions and so forth. The scope has totally changed. I mean, the first thing that Steptoe worked on was just the block tubes, and then it was one of their lab people, Dr. Jack Cohen, who was in Cambridge, who was the first in '84, so 6 years later, to think, why don't we use it for men? And this has become now the revolutionary treatment for men, as I'll show you in a few minutes. But until then, from the beginning of humanity till 1984 or till 91, when ICSI was developed, there was no treatment for male infertility. I mean, you go to a guy for male infertility, you go to the most famous urologist in the world, they keep doing exams and tests and so on, but treatment was nothing, was zero. The outcome of pregnancy was 0%. So Jack Cohen was the first he's now in St. Barnabas in New Jersey, and he worked in Cornell for a period of time. Endometriosis, as you will see, is of course a difficult disease to conquer because of its effect on the oocytes as well as its effect on the uterus, as we'll discuss. So bit by bit, many of the frontiers have been conquered. One of the things that remain very difficult is many of the religious institutes found it very difficult for them to accept that the egg and the sperm meet in vitro as opposed to inside the body. So this was the major opposition. I mean, there were several oppositions, but this was the major opposition by the Catholic hospital, by the Catholic Church. So in the U.S., in San Antonio, in a small Catholic hospital, one of the gynecologists, his name was Ricardo Ash, was doing a tubal reanastomosis. So the patient was ovulating at the time. He aspirated the egg, put it in the tube, and took the husband's sperms and put them in the tube. It was an open tubal anastomosis, and after he put the egg and the sperm in the tube, sewed the tube. He did a tubal anastomosis. So this was Ricardo Ash. Years later, he said, well, what about women who do not have tubal disease? Can't I just take the eggs and the sperms and put them in the tube? And he did what is known as gamete, which is basically an egg and the sperm, not an embryo, intrafallopian transfer. And it became the most successful treatment, and really the whole U.S. moved to gift in the mid-'80s. And they moved to gift for two reasons. One, it's accepted. Two, it was easy. There was no lab. There was no laboratory that is needed for IVF. 2 years later, the group from Belgium, headed by Paul de Vrooy, decided, well, if you take the egg and the sperm, they might like each other, they might not like each other. Well, if they don't like each other, you still have an egg and sperm, nothing will happen, so you have no pregnancy. But if they like each other, you have a zygote, or what we call 2 pronuclear stage embryo. And if you put that in the tube, you might achieve a higher success. So Paul Devroy did what's called zygote intrafallopian transfer, which was also a significant advancement at the time. And then a group in Australia said, well, why do we put the zygote? Why don't we leave it a day, maybe 2 days, and have a 2-cell, 4-cell, and 8-cell? So this way, you really enhance the chances by eliminating the ones that do not progress. You really are not changing the course of events, but you're picking the ones who made it a step further. So tubal embryo transfer became an option for couples with infertility. A group from Singapore, and then actually our group in London at the time, did what is known as post. So the post was basically picking the eggs, putting a needle in the cul-de-sac and squirting those eggs, and taking the sperms from the husband and putting them also in the cul-de-sac and leaving it in the cul-de-sac to happen. So again, you don't need a lab, you don't need incubators, you don't need pH adjustments, you don't need all that hard work that goes with it. Amazingly, it worked. I mean, the pregnancy rate was about 18%. Not very high pregnancy rate. But the reality is it challenged the concepts in physiology textbook. You read any book, they tell you that fertilization happens at the junction between the inner 2/3 and the outer third of the fallopian tube. Well, here it is. We put the eggs and the sperms in the cul-de-sac, and pregnancies happen at the same rate as they would normally happen in those couples, showing that it is possible that the egg and the sperms got attracted and then fertilization did happen in the fallopian tube. It's also possible that the fertilization happened in the cul-de-sac and the whole embryo moved. I mean, we really do not know. But at least it challenges all these established concepts. Again, all this time, we did the largest trial ever for male infertility. I'm talking male infertility like men who have almost zero sperms, zero sperms. I mean, close to zero. But they have still some in the ejaculate. We did these trials in 1988 to 1990, and we achieved a 0 to 2% pregnancy rate. So for every 100 couples that came to Cambridge, we got 2% if we were very lucky, and many years we got 0% pregnancy rate in those. And the reason is that those sperms are not capable of fertilization. So this is 4 stages in development that happened over a decade. This was first just the IVF. So here is an egg. The egg has a coat known as the zona pellucida, has a membrane known as the OLM membrane. So with conventional in vitro fertilization, you just put the sperms beside the egg. And then Jack Cohen, major contribution, he said, why don't you make a notch in that coat that may allow the weaker sperms, the immotile sperms, to get in. So he did what is known as partial zona dissection. So this is the zona pellucida, and if you take a little bit of it, then you have a partial zona dissection. And this was Jack Cohen's contribution. Well, another one of our embryology group, who actually later moved to Nottingham and in the UK, his name is Simon Fischel, said if you put a sugar solution, the egg shrinks away from the zona, then you can put the sperm in the subzonal area, so he called the SUSI, or subzonal insemination. And then it was finally in 1991 that actually an Italian guy by the name of Jean-Pierre Palermo, he was in Brussels doing his postdoc, totally unknown guy, couldn't get a job in Italy, moved to Brussels to progress his career, and then one day, by mistake, he injected the egg into the cytoplasm. Patient had 1 egg, so they kept it aside and they told the patient, and then the next day they replaced it, and then finally she got pregnant. And this was the beginning of ICSI. So this was the beginning of treatment of all male infertility. Depending on where you are in the world, ICSI is done more than IVF today. So for example, in the US, because of the concern of lack of fertilization, if you just put a bunch of sperm beside the egg, then ICSI is done almost routinely in the whole country. In the Mediterranean, in the Middle East, in the Far East, because most of the people who pay for IVF are men, so ICSI is done as much as 4 times IVF. So if you look at the global picture, about 80% ICSI, 20% IVF, because of different cultural and social concepts. But if the husband has a male infertility, the patient had a 10 times chance that they will go a procedure than, for example, if she had a tubal blockage. That's the reality. That is what's happening today and last 10 years and so on. The pie has changed. This I bring from you was from the United States report in 1995, 20 years ago almost in the time. And you can find that the majority of the patients that were coming for IVF are basically women whose tubes are blocked or so forth, male factor unknown and so. Today, basically the pie is equally distributed. A third of the causes are male, a third are female, and actually we say a third are mixed, but in reality more than a third are mixed. Every time we look back at the SART data, more than a third of those are mixed indeed. I'll tell you two or three examples that tells you what challenges those patients go through, and then again how those challenges have been conquered. So actually this was our first ICSI here almost 20 years ago today. The patient is still with us. She's actually currently a nurse practitioner here. She was 36 years old, and her husband was 50. He was married, had 2 kids, had a vasectomy. Dr. Charles White reversed it twice. It didn't work. I mean, he remained azoospermic after that. She was 36 years old. She had stage 4 endometriosis. She came here. Actually, Dr. Helva was my partner at the time, so he advised her to go for a total abdominal hysterectomy because she had stage 4 endometriosis. She had all the classic symptoms, and it was the right appropriate treatment. Well, her husband happens to hear that we're doing something called ICSI at the time, and so on. So he comes, and he's a forceful guy. So he convinces us to try. We scheduled first of all, he has the vasectomy that didn't work, so we have to go for the epididymis or the testicle to get his sperm. This was the first challenge. Second, she was 36 with stage 4 endometriosis. Her ovaries are almost gone. I mean, almost gone naturally. I mean, there is very, very hard to stimulate. We give her a bunch of drugs, and she makes a follicle or 2. So we had her, and actually we scheduled her at the Mobile Infirmary an early Sunday morning to do, and Dr. Charles White came. The guy is well known locally. He's the head of one of the music bands and plays at the Bienville Club and the Grand Hotel and so on. So the evening before there was a wedding, Dr. White was in the wedding. The guy was the head of the band. They played till the morning. So the morning both of them came tired and weary. I mean, Dr. White has never seen a procedure. I mean, he just is waiting for our direction, do this, do that. I mean, he's a fantastic surgeon, but he's never even, tackled that before. They got one of my friends. He's from Germany, from Ulm in the south of Germany. He came over to basically to do the first ICSI procedure ever here. So and he's a heavy pipe smoker. So he went to the OR, the infirmary, went up, had like 10 puffs, and then went back inside. And they had literally microsurgical instruments from here till the end of this hospital. Every instrument, every surgical tool that you need for a microsurgical operation was laid out for us to do the case. So my friend comes to Dr. White and say, okay, what I really need you to do is that you hold the testicle between your forefinger and middle finger, turn it 45 degrees, take that syringe with the green needle, stick it up, and then pull the plunger and give it to me. So Dr. Charles White looks at me and says, well, I don't know this guy, but I know one thing, that you and I will talk to that patient tomorrow morning and tell him what happened. So what do you think? I told him, just do, whatever he does. So he pulled the plunger and gave him the syringe. He had a microscope that one of the screws has fell off, so he could look at it, and he said, I think we're okay, we're done. He said, we're done. What do you mean? He said, we're good. We had like 60 sperms, and she had 2 eggs, 2 follicles, that we got 2 eggs, and he injected them, and she had a girl. We froze the remaining 20 sperms, and 2 years later she came back. She was 38, and we had 20 frozen sperms. So we thought he came back again, and we thought the frozen sperms. So there was the first frozen thawed epididymal aspiration, and we injected her single follicle, and she had a boy. So she had actually a boy and a girl at the time. This was almost 6 months later. This couple was actually from Biloxi, Mississippi. She was 37. Her tubes were blocked from a previous infection. He was 47, severe male factor. We took it, and by the time things were better, so we were courageous enough. We put 3 embryos, and the 3 of them took, and she was a happy camper at the time. Of course, today we put only 2 embryos, but 3 embryos at the time was a sign that of virility, basically, of that you can do it. That is the message. But not all the cases went so happily and so well. So the success stories on one hand are also paralleled by an equal group of very bitter cases. So actually this was a couple that came down from Atlanta at the time. She was 20 years old, a young lady with polycystic ovarian syndrome, obese, short, hirsute, amenorrheic, every feature of PCOS. He was 34-year-old with azoospermia. He had no sperms. With normal FSH, they did a testicular biopsy on him in Atlanta and said, yeah, there are some sperms in the testicles, but in the ejaculator they were not. They came down on a Monday morning here together with her mom, his mother-in-law. The three come in the morning. I see them do bunch of tests, ultrasounds, hormones, and so on. Then scheduled to have like a consultation with them as the first patient in the afternoon. So they come in the afternoon, and the mother-in-law starts, the discussion. The two guys are, the husband and wife are both sitting quiet, looking at the floor, and she looks at me and say, "Okay, so what is the plan? What are you, what's the problem? What are you going to do?" So I told her we need to do ICSI, and I went on, straight away describing we do this and that and so on. Said, "Hold on," and said, "So what's the problem?" I told her, "What do you mean, what's the problem?" She said, "Well, what is this, what's their problem?" I said, "Well, I thought you knew about it. I mean, they can't have babies because he does not produce sperm, and that's why we're going for, testicular biopsy to get the sperms to inject." So he said, if you can't even know, what's the problem, like why doesn't he produce sperm, why do I expect that you would be able to solve that problem if you don't even know what is happening? And so I thought, well, the situation isn't going that well, and both of them are quiet. I thought, well, if you really want us to find out, I can do a biopsy and send the genetics. She said, "Do what you need to do, but figure it out. I mean, you're going to treat her. You don't even know what's, the problem." So we actually did a testicular biopsy, and until that time, it was well known that all the male causes for male infertility are because of problems on the short arm of the Y chromosome. So this was actually, she had a translocation of chromosome 15, and this was possibly part of the problem at the time. And we stimulated her very hard, and as you know, polycystic ovaries make lots of eggs. We got 21 eggs. We found in his testicular biopsy about 18 sperms. We injected 18 of the 21 eggs. We had 5 embryos, and then we replaced them, and she never got pregnant. And she was extremely depressed about it. So what I want to tell you is that not all the cases end up happily. A good proportion of those patients remain infertile. So what are the challenges? There are really several challenges. Biological challenges like age, hormonal challenges like ovulation, and the majority of women ovulate. But you have two extremes: those who do not make eggs, called poor responders, or those who are excessive responders, like polycystic ovarian. So they're about 5-10% at this end, and 5-10%. This contributes to all our life problems, those 10% of people, the very poor responders and the over-responders. The majority of the other in between never have a problem, and we never see them. So we only see those who are challenging. Age is the single most challenging factor. The only thing that you cannot reverse is age. You can reverse everything, but as Henry VIII say, time, you cannot get time back. So I think this is the most true statement. This was actually our work in 1989. We published that in The Lancet in London in 91, based on 3,500 consecutive embryo transfer in 4,700 IVF cycles. We looked at the group of women who did 6 or more IVF consecutive cycles at our center, which was literally one of 4 centers in the UK and one of literally 8 centers in the worldwide, and looked at the pregnancy rate in relation to age. You find the younger women, those who are 25, had the highest pregnancy rate, and this after 6 cycles. And this is, of course, 1989, more than 25 years ago today. But you look at the older women, those who are 40, after 6 cycles in one of the best IVF centers in the world, the pregnancy rate was 12%. So it shows you that age is the most significant factor. So honestly, the best advice that somebody gives to anyone is to move early. The worst advice is tell them, take a 6 month, take a year, and so on, and take a vacation or take this, because nothing gets better with age. Very few things get better with age. So egg, I told you that the poor responders are those who are not making enough eggs, and over responders are those who are making over too many eggs. The poor responders, bunch of ways to overcome them. In reality, they are one of the biggest challenges. Many of those patients in this day and age end up with egg donation. But what we were trying to advocate is change the course of events. That those women, at some point, were better responders. Not necessarily they were normal, but a 38-year-old who produces 1 follicle after giving that much of drugs, when she was 28, she produced that much of drugs with that much drugs, the same amount of follicles. So theoretically, in 2014, you can offer what is known as social egg freezing. So egg freezing transformed that, because the problem with many of the two groups of people, the career women and the cancer patients. So the cancer patients can predict when they're going to develop cancer. So you have, everybody, treats their patients. They need to treat them fast and swift and so on. And every month or two, we get a call from the hospital. They say, well, we have this 19-year-old, she has osteosarcoma, and we need you to do something for her. And say, well, when are you planning treatment? They say, well, at 1 o'clock in the afternoon. Well, it doesn't work this way. You need at least a week, 10 days, 2 weeks to stimulate those patients to get some eggs, or even to attempt to retrieve their own eggs. But there are also so many career women. I mean, every day today we have, the doctors, dentists, whatever, lawyers and so on, that are just not decided when they're going to get married and when they're going to have children. Well, for those patients, or for those normal people who are not patients yet, you can easily retrieve their eggs and freeze them. And you can freeze them for 5 years, 10 years, and so on. 20 years ago, this was impossible. I mean, simply impossible, and I'll show you why in a second. But today, that is very, very doable. It's actually one of the simpler techniques. And the sad part is it does not require any laboratory fascinating equipment. So as opposed to, for example, the old freezing used to have programs and so on, the new freezing just have somebody who's familiar with the lab steps, and it is done in something like 15 or 20 minutes. And the eggs could stay when she gets married. If she gets married, she can thaw those eggs, inject the sperms. It will have to be ICSI by injection, and then put those embryos back. As opposed to those women who have excessive, who have poor response, there is the other women who have excessive response, called the ovarian hyperstimulation syndrome. And I've actually personally worked on that focused area for literally 25 years today, consistently and so forth. And one looks back, stands back quietly and looks back at, like your work over 20 years or 30 years, and then you publish a lot or a little, or contribute a lot or a little, it doesn't matter. When you look at it, you find that most of it is just chat. I mean, just the presentations of cases happen, things like that, series of studies comparing extra. Two things really stand out. One was the work on how does the hyperstimulation happen? How do you give somebody a drug and then suddenly get an ovary that was an almond size or a lemon size to become literally a melon size, have a belly full of fluid, basically have acidic fluid in the uterus, have fluid on the lung pleural effusion, get hemoconcentration, renal shutdown, kidney failure, adult respiratory distress syndrome in 1 week. So you took a patient who's 29-year-old, came to you healthy, riding on a bike, and then you give her a bunch of drugs. Her ovaries are normal. A week or two later, she has ascites. She walks. She can breathe because her diaphragm cannot move up or down. And suddenly, and really, it was a combined work that we did together with people from Belgium, from Germany, and others that deciphered what happens. And until now, we're not sure 100%, but we are sure at least that 3 or 4 things do happen. The biggest of them is that the shot that we give to mature the eggs is called the HCG, the human chorionic, which you measure in all the pregnancies, stimulates the ovary to produce a factor. That factor opens up the capillaries and opens up the spaces between the cells lining the capillaries. So you have suddenly acidic fluid. You have suddenly leakage of fluid, 100 times the speed of cancer patients, 100 more than that time. So really working on that has worked either on symptoms, which is again the standard treatment in medicine, that you cure what happened, or you deal with what happened. You didn't deal with what's the problem, as that lady used to say. But the other thing is to actually try to challenge the course. So vascular endothelial growth factor is probably the single most important factor. What about challenges in male? 2 challenges in the males. There are men who simply cannot ejaculate the sperms for a variety of reasons. Like what? Like injury. Somebody falls from a second roof, breaks his back, become paralyzed. That's one. Severe diabetes, neuropathy. 2. Prostatic cancer, and so on. So for those men that cannot ejaculate. And then there is the other group of men who don't have sperms, are azoospermic. And we'll see. With the ejaculation, basically one of the major advancements was the development of the rectal electroejaculation. The rectal electroejaculation, even in men who are paralyzed, you can stimulate the ejaculation as long as they, of course, have normal sperm. So this was the first case in the world that was done. This was Professor Edwards that I showed you his picture, but this is 20 years later. This was 1988. This is Paul Rainsbury, one of our partners there, is from Cork in Ireland. And this was the first patient ever. He, as you see, is a very healthy, strong man. He was a roofer. He worked on the roof. He fell down, broke his back, became paralyzed. Very, very strong man. Paul did his rectal electroejaculation, got the sperms, and this was the first baby born. Today in the U.S., the U.S. is in Washington, D.C., in the major rehab hospital. This is the lead center in the world for neurosurgical development and also for ancillary services. One of the guys, he actually came to us 10 years ago and said the rectal electroejaculation for this patient. They are very rare. I mean, there are not many people that are paralyzed and so on and still want to do assisted reproductive technology, but certainly it's an option to many of them. For the other men, it is really the problem is that there are no sperms. They ejaculate, but there is zero sperms in the ejaculate. This could be a plumbing problem, basically an obstruction. Or it could be actually a factory problem, that the testicles cannot mature the eggs to give them there. For the first case, which is the problem, really the management was totally revolutionized by Dr. Sherman Silber, one of the urologists at St. Louis. And we work with him on a regular basis. Actually, I go and operate with him many times at his hospital, at St. Luke's Hospital over there. He was the world first to do a testicular transplant. Although he was the urologist, he was the world's first to do, he did actually 9 cases of ovarian transplants between twins. So one of the twins, twin girls, one of the twins has premature ovarian failure, the other is still functioning. He took the ovarian cortex and put the first patient was from Alabama here, who was actually from Muscle Shoals, Alabama, and he did her 4 years ago. Sherman Silber was the first to open the epididymis microsurgically, and he's a fantastic, phenomenal microsurgeon of the old school and phenomenal guy. The way that I mentioned to you that Dr. White did that procedure was a percutaneous epididymal aspiration. Basically, you just hold the epididymis, and as long as there is an obstruction, like a vasectomy, the epididymis is swollen with seminal, with a little bit of fluid. So you can aspirate that. If there is no obstruction, there is no swelling, it's very difficult to aspirate, as you can imagine, something that is not distended. If all this first, you can go testicular biopsy. Testicular biopsy is a long topic in its own, but 50% of those men will eventually have sperms in the testicle. Not 50% will get pregnant, but 50% when you do a biopsy, you will find sperms, and 50 will not, depending on the genetic arrangements in the short arm of the Y chromosome. There is something called microdeletions, and there is several kinds of microdeletion called AZF. So there is AZF A, B, and C, and depending on which one of them, you can find or not find sperm in those patients. These were the studies that were done. One of the problems is movement. You have that you get sperms, but they don't move. I mean, the couple, he ejaculates sperm, but they don't move, or you do a testicular biopsy and the sperms move. Well, what is the challenge with that? You don't know if the sperm is alive or dead. I mean, it could be dead or it could be alive. So one of the things we used in the is trying to give it pentoxifyl. So pentoxifyl is like coffee. It's a phosphodiesterase inhibitors, increases the cyclic AMP, so increases the movement of the sperms, and it did help. The next few pictures I want to show you they are related to spermatid injection, although really we do not do spermatid, we do sperm injection, but it shows you the same concept. So this is what's called injecting pipette, which is very, very, very tiny. This is magnified 40 times. And you took the sperm and aspirate it inside that pipette. And then you put another pipette called the holding pipette so that the egg does not keep running away, and you hold it. The egg at the time of ovulation, resumes ovulation, so throws out the polar body. So you keep the polar body at one end, either here or there. Most people keep it up there. So you turn it round and round until it stays up there. Why does it stay up there in particular? There is a spindle, as you remember, there is a meiotic spindle. You don't want to slash that meiotic spindle with needle. Remember, we do not see the meiotic spindle, although there is a microscope that could visualize that, has been popularized in Tampa, Florida, and in New York. And then we take the injecting pipette, and you can still see the sperm there, and put it through. So it will have to go through the zona pellucida, and then that olemma, olemma member, and then the olemma, and then gets inside the cytoplasm of the egg. So if you look here, it indents it. You can see that is almost folded, because really in 3D this is a sphere. and then you push it until you almost go to the other side, and you can see the sperm is deposited here. And then when you withdraw, you have to look. When you withdraw, you almost leave a groove. Unless you leave a groove, you could be in front of it or behind it. I mean, because this is not 3D. Although the person doing it has a modulator on the microscope called Hoffman modulator that makes it a bit of a 3D. This is a mature, nice egg with what is known as the corona radiata, sunshine, and so on. So this is a nice egg on a Sunday morning, as opposed to this one, over mature, cracked egg, dark cytoplasm, dead egg, totally useless, will never result in a pregnancy. When the eggs and the sperms mix, the egg produces the second polar body. So this is the body, the egg's mechanism to have its chromosome complement from 46XX to 23X, and then it takes the sperm, which could be 23X or 23Y, and then results into two polar bodies. Two pronuclei. So the evidence of the presence of two pronuclei suggests that a sperm has fertilized an egg. Well, what happens if you see three of them? If you are doing in vitro fertilization, then it could mean that a second sperm went inside. So normally when one sperm goes, the egg produces a bunch of granules that blocks another sperm from coming. If this mechanism fails, usually as a result of age, then another sperm could come in, and if you leave that, it will result in a hydatidiform mole. So if you miss that step and keep it on, the embryo will divide totally normally, and you can never tell which one was good and which one was bad. It's a very deceiving thing. So if it divides, it becomes a 2-cell. And then if it divides more, it becomes a 4-cell. So you can see here, this is 1, 2, 3, and 4. And then if it divides more, it's an 8-cell, which is day 8, which is the most time we do. If you have 1 or 2 eggs, it really doesn't matter whether you put it in on day 0, day 1, day 2, day 3, because you're not selecting any. If you have 10, you're waiting because the time will allow you to see what will happen. So if I have 10 and only 3 fertilize, or 1 fertilize, or 2 fertilize, then really it doesn't matter. It doesn't enhance the pregnancy rate to wait longer. Of course, if you have 10 and by day 3, 8 of them are 8 cells, then you let them stay longer and you develop a blastocyst. And these are the cases who are almost guaranteed a pregnancy. Not only that, but you can also put 1 embryo only, because the chance of pregnancy from that single embryo, and we say the implantation rate of an embryo is anywhere from 20% to 50%. If you have a blastocyst, it's 50% per embryo, not per and so on. So this is a big movement in Europe, where many of the IVF programs are paid by the governments that they have to put 1 embryo. They cannot put 2. In some places like the UK, they allow you to put 2, although they frown upon you. And until recently, by law, you were allowed a multiple pregnancy, and by multiple pregnancy, twin, to be less than 10%, which is extremely difficult to achieve, because if you only knew who's going to do what, you would have already chosen. This was challenged in court last year, and the challengers won against the government, and they actually now allow them to put 2, and do not insist that they have to have a twin rate of less than 10%. Sometimes the embryo look great, sometimes they fragment. If they fragment like that, one of the people, again, Jack Cohen in New Jersey, and some of his Mina Alikani, some of his lab partners, opened the zona pellucida and took the fragments out in the hope that you can actually diminish the metabolic consequences of fragmented embryos on there. Again, one of the major achievements that happens, so beside the egg freezing, beside the ovarian transplantation, which are the 2 most significant advances of the last decade, from 2000 to now, the egg freezing and the ovarian transplant. The third thing is genetic determination of the embryo. Because today, for a cost of less than $1,500, you can tell which embryo has normal chromosome 13, 18, 21, X and Y. So what the perinatologists, and I don't see any perinatologists here today, so I can speak freely, what they do in all their career, literally you can do in 6 hours using fish fluorescent in situ hybridization. You open the embryo and you take 1 cell out of the egg. We have a group from Chicago that they come. We do not do any genetics on site here. There's nobody that does genetics on a single cell here. So we have a group from Chicago that they come. The guy, they are actually all Russian, because the guy that that developed the field. He passed away from cancer 2 years ago. His name is Yuri Verlinsky. Yuri Verlinsky set an institute of genetics in Chicago. Literally all they do is genetics, and they have like 34 centers global, worldwide. So one of the Russian docs come down and does it for us. And honestly, every time I look at him doing the things, he turns around the embryo, opens the coat, and takes one cell with a more precision and speed than most people would, like open a uterus, take out the fibroid that is 10 centimeter and take it out. Literally, he moves it with the two in 3 directions, and so on. Standing, opens, makes a hole in the coat, takes out one cell, puts it on the slide. 1, 2, 3. I mean, he came one time. I came on time. He did the 8 eggs in maybe like 6 minutes. So these people are very, very handy, to say the least. But this has opened the field for many things for genetic disease. And some of the major centers in the U.S., in New Jersey, are pushing for what is known as complete genomic hybridization. Basically, that you check the whole thing, not you check chromosome to it. So basically, I give you an embryo, you check for it, particularly if there is a family history of a certain disease or not. What about putting embryos back? This famous story a decade ago from Iowa. They had a bunch of drugs. They never monitored them and so on. So she ended up with 7 babies. So they were from a little town called Carlisle. She went back to the town. The whole population was 3,400 when they were back 3,407. Not a very good advertisement for IVF. One last thing, I mean, the challenge for putting more was because we couldn't get pregnancies with less. So this was actually our work published in 1992 that we published in 1992, looking at those patients who had 1 embryo transfer, 2, 3, and 4. And you can see that those who had 4 had more. But remember that those patients that had 2 because they only had 2 embryos. So those who had 1 had 1 not because they wanted to have 1, because we only had 1 follicle, 1 embryo. So these are by nature limited by that. You cannot extrapolate that to patients who have 6 good embryos and you pick 1 or 2 or 3. Definitely we recommend that you do not put more than 2 in somebody who has 6 good embryos. This is the outcome of 558 of those patients that I followed through. This I published with Professor Edwards 24 years ago now, and show you the singleton twins. And so we did a weekly ultrasound from week 4. So basically the day the pregnancy is positive, we did weekly ultrasound. Besides that, we were measuring a few other things for interest. From an OBGYN, one of the major things to take care of is the obstetric management of those patients. They have more complications than ever. Most of those complications are related to the placenta, not to the baby. But there is a tremendously high incidence of placenta previa, of early delivery, of low birth weight, even when you take singleton for singleton. Of course, the majority are because of multiple. But even when you take single to single, those patients have and possibly a higher chance of abruption, certainly a very high chance of cesarean section. So the obstetric management of those patients is extremely tricky, and we published the first paper on that. It was actually a landmark paper, and not because just because the paper was good. It was because we deciphered the congenital anomalies in the first 1,000 IVF babies born worldwide. So this was the first 1,000 IVF babies that were born from 1980 to 1988, and we did it together with Pat Doyle, who was our statistician from the London School of Hygiene, S.L. Pan, who was his current chair at McGill, and Professor Edwards. So this was the first 1,000 babies that were born. At the time, we showed that the congenital anomalies were similar to the rest of the population in the UK, but as the years went on and ICSI became involved, the chances of congenital anomalies with ICSI is much higher, particularly if the husband had a male factor. If he has a son, his son would carry the majority of the problems that the dad has. And I end my talk with this slide. This was actually 1,000 babies. All those were IVF babies. And the first one is the front, is the girl that I showed you at the beginning when Louise Brown, she was 10 years old at that point, and she was carrying on her lap the 1,000 baby. This was the front garden for that house in Cambridge that the nice American lady gave to Professor Edwards in 1981. And I thank you for your attention this morning, and would be glad to answer any questions if you have any.
Just to clarify, Iowa was not IVF, correct?
I'm sorry?
Iowa.
No. Was
Was
gonadotropins. Yeah, was gonadotropins. Exactly. Yeah.
You don't want to give IVF that.
Yeah, absolutely. Well, there is only one in California that had IVF and ended up with 8 Octomom. I think that was the only one that is reported worldwide, and she's written many books about it.
Rizk, have you had any cases of a postmenopausal woman coming in wanting to get pregnant?
Lots of those. And one of the most controversial issues in this field is how long are you going to extend the chances of pregnancy? Indeed, in Italy, in Rome, one of the gynecologists, his name is Antinori. Antinori has a big IVF center, but has a whole center dedicated to women above the age of 50 that want to have babies. So they come to his center in Rome, and basically all are egg donors from nice young Italian ladies and so on. So very healthy eggs, no infertility, nothing at all. And he published the obstetric outcome. The obstetric outcome is marred with a little bit higher complication, but not really significantly higher to what you compare. Like the IVF group by themselves have lots of obstetric problems, which is similar to themselves if they had just fertility treatment, which is an amazing thing. Like, I mean, if you look at the ICSI-IVF and fertility treatment, all the three have the same obstetric problem. You look at those from 50 to 60, I mean, they have more hypertension and heart problems. And minor, I mean, by medical acquaintance, it is not high. We see a significant number of those now. I mean, significant number of patients in their very late 40s, I mean, from 48 to 53 that are coming now. We've never seen that before. The sad part is that many of them are still wanting to try and use their own eggs, where the chance today in those people using all the technology remains between 0% and 1%. Yeah, of course, every one of us has a patient that was 49 and came and told them I missed the one period. But the pregnancies in those are very poor. The egg donor has changed radically in the last 10 years for those patients. It really has changed dramatically. If you look at the previous 20 years, all those couples were basically the following story. Young couple with PID, can't afford IVF. Older couple with money can afford IVF. The older couple pays for the 2 cycles, and the younger one gives her eggs to that one. Of course, it was fraught with at least some ethical concerns or ethical kind of discomfort, to say the least. What changed, and I really never liked that idea to start with, but what changed it totally is the egg freezing. So in our region, in our big region, one of the groups in Atlanta, and they're very close collaborators, Peter Nagy, he's a Hungarian guy that trained in Brussels and moved to Atlanta. He is an MD, PhD. He worked for 2 or 3 years, and Hilton Court was the head gynecologist in the group, to try to recruit egg donors from the college students in Atlanta. And with as much colleges as there are there, he was able to freeze the eggs from those young people as donors. And he keeps the eggs in a bank. So he had, for example, 100 different profiles for people with egg. So if you have a 43-year-old that has tried and failed or miscarried several times, you do not have to find another 20-year-old who have PID or had this or had that, and then you match them and you match their cycles and so on. You simply could use their eggs. You can even let him send the eggs to you, and you inject them with the husband's sperms here. I mean, it is really, really easy because of vitrification. So the vitrification is basically quick freezing. So it makes glass instead of ice. With the old freezing, it made ice. The cell is big, the egg is big, so the small ice particles, when you thaw it, they expand and they burst the egg. So you start with a good egg and the technique works and you freeze it well. But when you thaw it, it expands and bursts. The vitrification, it's very rapid freezing. Literally, I mean, I have some cartoons to show. It's like jumping from top of mountain in the ocean in one shot as opposed to a gradual decline. So you make almost the egg inside as a glass. So when you thaw it, it doesn't burst. There is no ice particles that burst. And the egg freezing has revolutionized the world. Again, for the social freezing, for those women who have missed the boat, I mean, somebody who's 37, 38, Her only options were adoption, but now she can use egg donor from somebody who's already been screened and profiled and so forth, and then you can match profiles. Also, you can provide ethnic groups. I mean, again, I mean, if in a big place like Atlanta, you can provide, so for example, an African American population or an Eastern European population or even Asian population in that group. So out of but very few centers could hold an egg bank. I mean, in the U.S. there are several egg banks. I mean, in our region, Atlanta, is the major place where this has happened to on a major scale enough to generate. Of course, the egg freezing is so easy that anybody that comes to us now and say, for example, I'm 30. I mean, we had somebody who's a dentist a few weeks ago. I mean, she's 35 and she's not decided she will get married and she will have children, but she's not decided when and if. And every time we check, her anti-Mullerian hormone is going down. So we told her, well, we freeze the eggs. We stimulated her. One time we got 4 eggs. One time we got 5. We froze 9 eggs. So assuming a 50% chance that those will fertilize and all that stuff, she still has a good chance. But indeed, the pregnancy in older women, what is the limit? I mean, really, there is. It used to be 40, then 50, then 60, but all those are egg donors. Are not really their own. The oldest we have treated using her own eggs, and she delivered the baby herself, was 45 successfully. I mean, we've tried. One famous person internationally, she was 49, but we failed. We tried her several times. Her husband wanted somebody to be the heir to his, throne at the time and so forth. So although he had several wives at the time, I mean, he wanted that the heir would come from her. So we tried many attempts and we totally failed. She was 49, but the oldest that we had that she delivered her own baby was 45 years old. We did a previous treatment when she was 36 and was successful, and in between did 5 cycles that either resulted in a miscarriage or an ectopic. Well, thank you again. You have a wonderful morning, and we meet again here. Thank you.